Thanks for coming. I hope you're enjoying this 12-week course. Everybody that I see in the clinic tells me how incredible it is. And I really see some amazing things happen to people who are exercising. It's as good as medication. It is a medication as far as I'm concerned. So I think you're doing a great thing. So we're going to talk about very, very briefly some of the clinical features of Parkinson's disease, mostly to talk about the medications, why we use them, a little bit of how they work within this framework. The top three features here, rigidity of the muscles, the cogwheeling rigidity that I talk with people about, sort of a ratchety muscle tone, bradykinesia, really kind of the foundation of a diagnosis of Parkinsonism, most of the time caused by Parkinson's disease. Bradykinesia is slow movement, but importantly, to differentiate Parkinson's disease away from other types of movement disorders that are slow, bradykinesia involves reduced amplitude of movement. So if your doctors have you do a maneuver like this, they're looking to see if a hand, the amplitude should be nice and big, and over time with Parkinson's it may get kind of small. So reduced amplitude in addition to speed is critical to define Parkinson's disease away from something like a dystonia or other movement disorder that might cause slowing of movement. Tremor is the third feature. Usually with Parkinson's disease we call it a resting tremor, so when gravity is removed from the limb, the tremor will develop. Against gravity or with use, the tremor will calm, but that tremor can then come back against gravity or with use. So it's not a line in the sand, so to speak. But those three features there, the rigidity of the muscles, the slow reduced amplitude of movement, and tremor, are what we call the cardinal motor or movement features of Parkinsonism. Most of the time, Parkinsonism is caused by Parkinson's disease. And these three features here, the rigidity, bradykinesia, and tremor, are the motor or movement features that are most driven by the dopamine chemical system in the brain that we use medications to replace and try to calm the symptoms. When we think about the treatment stages of Parkinson's disease, we're all born, we all die at some point. That's just what happens to us humans. Parkinson's disease itself, the average age of onset is about 62. Based on pathological studies, we really think that Parkinson's disease is developing probably 5 or 10 years before the onset in someone's brain. So that's why we have kind of a very slow progression towards diagnosis, and you may think back when you first started developing a little bit of tremor, a little bit of slowness, that the doctors weren't quite sure. And that happens to me all the time. Someone comes in, they've got a tremor, I'm not 100% sure they have Parkinson's disease. There are some things that kind of look like it, but I'm not sure yet because it's been there for a while. It's developing very, very slowly. Now maybe out in here, with the clinical features that are apparent 10, 15, 20 years in, it's easier to diagnose. But sometimes around the time of the first development of the symptoms, it can be a little bit difficult. And then after the clinical age of onset, then we have this sub-timeline here of treatment. The gray zone on your far left is a period of time when we're really not sure whether we should treat or not. And by treat, I'm talking about using medications. As soon as, actually before anyone develops Parkinson's disease, they hopefully are exercising. I try. I do the best I can. It doesn't always work. But the treatment I'm talking about is medication. We do not need to put people on medication as soon as a tremor develops or as soon as someone notices that their hand dexterity has been reduced a bit. Right now in 2017, there's no strong evidence that any of the drugs that we're using for symptomatic benefit have a disease-modifying component, okay? So we don't have to put people on drugs right away. So that gray zone, I will say that the sizes of these blocks, I keep promising that I will get rid of this one, because I don't think I've ever seen this one, to be honest with you. And I keep promising that I'll change these blocks around, but I have a feeling I'm going to keep promising for years, because I don't seem to be able to get to it. The block sizes are different for different people. I have people that are 5, 6 years in, they just don't need a medication. They're exercising, they're doing their thing, they don't need a drug. They don't want a drug, and it's fine to not use one. Once you do decide with your doctor that it's time for a medication, you choose a medication based on a number of different criteria, and then you start using the medication. We're considering medical therapy as you're going through the gray zone period. When do we start? And then people usually say, you know what, I think it's time to start. The tremor's bothering me, or my hand is too tight, it's getting uncomfortable, whatever the case may be. And then for most people with Parkinson's disease, a honeymoon stage will develop. And that's not a medical term, so to speak. It's kind of what the docs call it, and sometimes people themselves call it, because you get on the medication. Medication works pretty well. Stiffness and slowness calm down, the tremor calms down, mobility is better. The honeymoon period hopefully will go back that way as you're getting into exercise. But that honeymoon period is a time when the medications work pretty well. You're not having problems with wearing off, or hopefully not side effects, and things are going pretty well. Now, again, key point, the size of the bars. Please don't pay attention to that, because I think most of it comes this way. After we've started medication, a person may start to go into a stage called where motor fluctuations start to occur. Not everybody gets to this, by the way, and sometimes people get it out here, okay? So again, don't pay attention to the bar size. Motor fluctuations simply mean, instead of a nice, smooth response to the medications through the whole period of the wakeful day, you might notice that the medication starts to wear off a bit. Medication that used to work for 4, 5, 6 hours, now it's not lasting as long. And you notice, boy, that tremor's starting to come back before I take my next dose of medication. Okay, so that's when doctors talk about the on, what is your on time? On means, is the medication working for you? Off means you're starting to notice that it wears off. So that's the fluctuation between on, it's working, off, it's starting to wear off. And then dyskinesias can be part of that phase as well. Dyskinesia is what we call choreiform movements, usually kind of some wiggly, dancey type movements that might happen when your brain is seeing a little bit too much of the dopamine replacement medication. Sometimes people get some twisting or pulling as a dystonia. And people can fluctuate between being on, responsive to medication, wearing off, or having even too much movement. And this stage, actually, it just takes a little bit more work with your doctor to try to find the right doses and the timing and mixture of medications to kind of keep you in the functional zone that you were in before for a longer period of time, okay? Again, failure, one of these days I'm really going to get this off of here, because in theory, if a person's brain is not able to take up, package, and use the medications anymore, then the medication won't work. I'm very commonly asked, I'm told that if you start drug X, it'll only work for 5 years and then it will stop working, so I need to hold off. Well, that's just not true. The medication will work as long as a person's brain is able to use the drug, okay? So I don't really think I've ever seen this. So one of these days I promise to get rid of it. Until then, I'll keep explaining why it's still there. In Parkinson's disease, the deep motor or movement centers of the brain that tell our brain how to get our arm to move smoothly and without tremor and at an appropriate speed to carry out the task use a chemical called dopamine. The dopamine is actually produced in the cell. It's stored at the end process of the cell, and then it's dumped out onto the next cell where it triggers receptors, dopamine receptors, to tell the next cell whatever the message is, move, okay? In Parkinson's disease, There are a number of things happening with the dopamine cells. One, they are starting to become dysfunctional and die slowly over time. There's also a bit of a packaging problem with the dopamine. So the ultimate effect is that the dopamine signaling from this cell to move or to not shake is impaired. The system that I'm speaking of specifically is in the midbrain, or the brainstem here. So this is a kind of a cut through the brain like this, and it's opened up, so you're looking towards the inner side. And in the brainstem, there's an area called the substantia nigra, and within the substantia nigra, pars compacta is the group of cells that make and use dopamine. And if we look in cross-section, the far left on the top, you can see that black band. Everybody see that? The black band is a gross view of the microscopic view here that has a lot of cells that have black pigment in them. That's neuromelanin. It's pigment very similar to the pigment in our skin when we get a tan, okay? So it's the anatomical structure is called the substantia nigra, the black substance. And on the top left, that's a brain of a person that did not have Parkinson's disease. You can see very distinct black bands there, and you can see here very distinct cell bodies, and lots of them there. In Parkinson's disease, the bottom panel is a person who passed away and had Parkinson's disease, and you can see, if you compare it to the image above it, you're not really seeing that black band so well, okay? And this is why. The cells, these dark pigmented cells, have very slowly, over decades, died. These are the cells that make dopamine telling the cells down the line to help with the movement. So histopathologically, that's what we see in Parkinson's disease. Now, I'm not sure how well this shows up with the lights, but I think everybody has heard of Lewy bodies. A Lewy body, this now is a cell. This little guy here is now magnified big. A Lewy body is basically, it's a compacted piece of protein, okay? So it's like having a marble build up inside a cell. It shouldn't be there, okay? So that's the pathological inclusion body in a Parkinson's disease cell. It's called a Lewy body after the man who identified the pathological finding. And people have heard of Lewy body disease, dementia with Lewy bodies. In Parkinson's disease, these cells are in a small number of regions of the brain. In Lewy body dementia, the Lewy body containing cells are much more broadly applied throughout the brain, causing cognitive and sometimes psychiatric problems. So we don't know if they're overlapping diseases on a spectrum. There's some evidence that they might be somewhat distinct disorders based on the form of the protein that builds up, but that gets beyond the discussion today. The substantia nigra down in here makes its dopamine, projects its communications to an area collectively called the striatum, and the striatum is where the substantia nigra cells are sending the dopamine signal. This we can actually look at in people while they're alive. This is a DAT scan, a dopamine transporter scan, if you've heard of that. What is happening is basically we're able to label the end process of the dopamine cell. We can kind of put a glove on the hand, so to speak, and the more gloved hands there are, the more signal we get. So on your far left, we get this comma shape on each side. That's a normal scan. That's normal numbers of these nerve cells contacting the striatal cells. If we go to the middle, you can see on your left the reduction in that comma shape, the reduction in the signal, and even the right side of that brain, there's a little bit of a reduction in signal. We don't really know why Parkinson's is so asymmetric, but it's part of the diagnostic criteria that one side of the body tends to be affected first and tends to stay more affected through the lifetime than the other. And we actually see that anatomically in terms of the reduction in these dopamine-containing cells. And this would be farther along in the process with more loss of cells. So this type of scan is available to help figure out whether someone has a Parkinsonian syndrome or not, but we don't use it now to quantify the amount of cell loss over time or to check on therapeutic response. It's just not how we use that right now. But we can actually see by live imaging the loss of the cells. So in Parkinson's disease, again, we're having some difficulty with dopamine signaling to the next cell. And so what we can do is we can use medications to try to beef up that signaling so that the tremor, the tightness of the muscles, the slowness of movement can calm down, to try to make this system work again. You've heard of pramipexole, ropinirole, rotigotine. This is the patch medication. These are called dopamine agonist drugs, and they act directly on the receptors. So they actually signal directly to this cell to try to make it work correctly. These work pretty well in clinical practice, but they're not acting the same way as the cell used to act, so sometimes they don't work quite as well as levodopa, which we'll talk about in a moment. So the dopamine agonist drugs, they do work for, again, those cardinal 3 motor or movement features of Parkinson's: the tremor, the rigidity, and the bradykinesia. They have a long half-life, and that simply means how long does it take for half of the drug to disappear in the blood. So a long half-life means it's sticking around for a long time. A short half-life means that it's not sticking around very long. So they last a long time in the bloodstream and then presumably in the brain, particularly compared to levodopa. So we think that they give more constant brain levels and perhaps a more physiological stimulation of these dopamine receptors that I just showed you. And there has been a lot of kind of controversial thought about whether this may confer some protection against the development of these fluctuations and dyskinesias that I talked about. There are reasons to use these drugs, sometimes in early stages, sometimes continued use, but there are a lot of different levels to that, so it really kind of depends on the clinical response, and there's really, the bolded part here is very true. It's controversial and not proven. So if you're not on one of these drugs, don't worry about it. A lot of the people that I see are not on these. There's not a protective benefit, okay? But this is why they might be used earlier in the course, because they kind of last a long time. Downside, compared to levodopa, in general they tend to be less beneficial than levodopa. Every once in a while I take somebody off one of these medications because they're having side effects, and it ends up being a bad plan because the medication was really working and then we put it back on. But don't know until we try. Try to do it gently, but sometimes it ends up not being a good thing. So this is not always true, but in general it is. Just like other dopamine agents, the medication is not as helpful for balance problems, freezing, postural instability, so the ability to make kind of quick corrective maneuvers if you get knocked to the side or off balance. These are features that go a bit beyond the dopamine system, and so this is where the exercise, the physical therapy, and the training of your brain to work around the dopamine system really helps. So just pushing the drug doesn't always get you where you want to go. And importantly, these dopamine agonist drugs are more likely on average than levodopa to make people tired, to cause hallucinations, to cause delusional thinking, so we really have to be careful with them. Dopaminergic side effects are, again, a bit more common than with levodopa. nausea, being lightheaded from blood pressure dropping, sometimes confusion. Sometimes people tell me that they think much more crisply on these drugs than off, and that does happen. Hallucinations, usually visual, people, animals, usually friendly, not always friendly. Sometimes delusional thinking, fatigue, and sometimes sudden fatigue. We used to call them sleep attacks, and maybe we still do, where people would try one of these dopamine agonist drugs and they'd fall asleep. And the reason it was called an attack was that people would try to drive through the fatigue and then they'd fall asleep. So we try to tell people to, don't do tightrope walking or ladder climbing the first day you're on these drugs. Make sure you're not in a position where you can't protect yourself, okay? Compulsive behavior, also something that's much more common with these dopamine agonist drugs. Gambling, shopping, hypersexuality, so sometimes these are dopaminergic side effects with these drugs. So again, these drugs are used as dopamine agonists to try to directly trigger the receptor. Levodopa is a metabolic precursor to dopamine, which is the chemical that cell has been used to using its entire life. And so what we're doing is giving that cell back dopamine. And my suspicion is that that's why levodopa tends to work better. You're giving the cell back what it's used to and allowing it to use it the way it's used to using it and the way it wants to use it. So levodopa tends to work best in most people. And the way levodopa works, you take a pill, right? There's a brain on the right, there's a line in the middle, and then on the left side is, let's just call it the bloodstream, once the pill gets into the bloodstream. Levodopa goes into the brain and is converted into dopamine, where it's used to help with movement. Now, levodopa on its own, only about 1% of the dose in the bloodstream will get into the brain. So levodopa, back in the 1960s, they used to just pound people with levodopa because you had to get so much in to get a little trickle to go into the brain. And what would happen is the same enzyme, AADC, that converts levodopa to dopamine in the brain also converts levodopa into dopamine in the gut and the bloodstream. So dopamine builds up in the bloodstream and causes blood pressure to drop and nausea to occur. And so these people were actually moving better, but they were passing out and throwing up all day. So partially in advance. So now, carbidopa, it's not just to make that pill impossible to pronounce, the carbidopa, levodopa. But what carbidopa does is it blocks this enzyme converting levodopa to dopamine. But guess what? When you give carbidopa in a pill, it does not get into the brain. It's stuck out in the bloodstream. So it only affects the enzyme in the bloodstream. So it's blocking the production of dopamine in the bloodstream. The levodopa just sits around, has no place else to go but into the brain. So basically that carbidopa is shunting that levodopa into the brain. The carbidopa can't get in the brain to block this enzyme, and you make a lot more dopamine. So you can reduce the dose immensely. Instead of thousands of milligrams of levodopa, you can take hundreds of milligrams of levodopa with carbidopa, get it into the brain, and because there isn't so much dopamine in the periphery, less vomiting and passing out. This is where Sinemet came from, without emesis or throwing up. So that's where Sinemet came from. So the good side, the levodopa, you can take it by mouth. It crosses the blood-brain barriers, it's called, gets into the brain. In most people, it's the most effective agent for those cardinal tremor, rigidity, bradykinesia movement symptoms. Relatively rapid onset of action, about half hour, 45 minutes, depending on the person. Carbidopa reduces that peripheral conversion to dopamine and concentrates the levodopa in the brain. Downside, very similar to the dopamine agonist drugs. Again, some of these aspects of Parkinson's that are later in the progression and may not be as closely tied to the dopamine signaling system may not respond as well. Similar types of side effect potential. Absorption is adversely affected by food and poor GI motility, gastrointestinal. The food I'm talking about really is protein. Levodopa is amino acid. A steak gets broken down into amino acids, so if you put a steak and levodopa together and it gets all churned up, they're all battling for the same uptake mechanism, and by mass, by competition, the levodopa is not going to get absorbed as well. So that's why I ask people to take it about a half hour before, an hour after meals. People have literally come to me and said, levodopa doesn't help me, but I take it with meals. You take it away from meals and all of a sudden, miraculously, levodopa helps you. So sometimes it's just as simple as an absorption issue, okay? And then, as I had said previously, the clinical effect can become less robust and long-lived with disease progression. Dyskinesias and the on-off motor fluctuations may develop. This has to do more with the machinery in the brain than actually using the drug. So I do see people who are reluctant to use levodopa because it's going to cause these problems. Honestly, when it's time to use it, you use it, and you can work with these problems if they develop. That's dopamine agonists, levodopa to make more dopamine. A third way that we can help out the dopamine system is to use drugs that reduce the breakdown of dopamine. So our bodies are pretty smart. They make a chemical, they use the chemical, and then they break it down. It's just like using stuff, put it in the trash can, the trash guys come and take it away. If we don't have the trash guys taking our stuff away, it's all going to build up, and society will just kind of go downstream from there. So it's the same in the brain. It's used, it's trashed, it's recycled, or broken down. And entacapone, rasagiline, tolcapone not used so much, selegiline not used so much, but these agents work on dopamine breakdown mechanisms to keep dopamine around longer, okay? So we can activate the receptors, we can make more dopamine, and we can slow down the breakdown of dopamine. All of these things are kind of building up the dopamine levels, so to speak. As a person moves from the honeymoon stage into the motor fluctuation dyskinesia stage, if they do, okay, so again, not everybody does. This is when we might consider the deep brain stimulation neurosurgery. Thoughts are changing on that a little bit. Do we use it earlier? Not quite there yet, but we can work with the medications. We can think about surgical procedures in terms of the management. Some of these other features here I've alluded to a bit through the talk. A forward flexed posture, postural instability. So, my 15-year-old kid, if I knock into him, he's not going anywhere. That's a postural reflex. He can make a quick corrective movement to keep his balance. In later stages of Parkinson's disease, a person may develop difficulty with this, so that a little knock may throw them off or make them more easily fall. Not as dopamine responsive, but the exercise, the Tai Chi, yoga, things like that to help with balance can really help with that. Freezing of gait, the foot doesn't move when you want it to, or you're walking along and you kind of freeze up and the legs are kind of stuck to the floor. Fascinating gait, where the steps are choppy, your upper body's getting ahead of the lower body. Poor balance falls, these are all later features that are not as strongly tied to the dopamine system, so more variable response to dopamine replacement medication, and much more important that you're thinking about a cane, exercise, balance training. And then the last is non-motor features. Thank you very much. And I can take a few questions. Does Parkinson's disease ever progress to dementia with Lewy body? So I would say that the answer is probably no to that. The distinction between the two is still being figured out. Another thing that I tell my 15-year-old kid is that dad goes to work and tries to fix an engine that he didn't build and he doesn't have a manual for, which is kind of true. So Parkinson's disease and Lewy body disease may be either opposite ends of the same spectrum of disorders, or they might be very separate disorders that have Lewy body pathology. So I typically don't, and the definition, the clinical definition right now for the Lewy body dementia is that if there are fluctuant cognitive problems that predate or develop within a year of the onset of motor Parkinsonism, slowness, stiffness, perhaps tremor, then it fits more after a person passes, their pathology will fit more with dementia with Lewy bodies. Whereas if the Parkinson's, the motor Parkinson's develops first, and then a year or more after that cognitive problems develop, then it's more likely to be what we call Parkinson disease-related dementia if cognitive problems happen. It's not like if you're 360 days, you're dementia with Lewy bodies, and you're 500 days. We don't have that kind of distinction. So I don't, can somebody with Lewy body dementia be diagnosed as Parkinson disease, and then with time and further progression of symptoms, the diagnosis is refined to be dementia with Lewy bodies? Certainly. So the other thing that's very interesting is the Lewy body itself, the main protein that builds up in that is something called alpha-synuclein. And what scientists are finding is that certain forms of alpha-synuclein tend to produce Parkinson disease, and certain forms of alpha-synuclein seem to produce Lewy body, more diffuse Lewy body disease. So I think that the simple answer to your question is no, that true Parkinson disease is not going to turn into dementia with Lewy bodies, but things can, I've seen people, we kind of subdivide all of the atypical Parkinsonisms now, and sometimes people who really look like Parkinson disease for several years will very much look like progressive supranuclear palsy 5-6 years in. Does that mean the initial diagnosis was wrong? Well, no. That's what we were calling it. So we don't do brain biopsies to stage and see what's going on. We do use our best clinical judgment to tell people what we think is going on. So that's a long answer to a simple question, but it's a tough, it's figuring out all these. The other thing is with Parkinson disease, there are so many variations of age of onset, of tremor or not so much tremor, fantastic response to medication, not so much of a response, or a lot of side effects, progression rate. There are probably hundreds of forms of brain disorders that we lump together as Parkinson disease, and there may be 100 subtypes that we ultimately define that cause a very tremor predominant that develops in the 50s, that responds great to levodopa, etc. We just see so much variation in what we lump together that, about 5 years ago, the movement disorders community as a whole was trying to define what is Parkinson disease. It's like we don't really know what it is because it can look so different across the board. So still a lot of work to do to even with basic definitions. Yep. Yeah, so the question is, do you use a dopamine agonist drug with levodopa, or do you just use one separate from the other, and is there a reason to use both at the same time or to avoid using both? And honestly, it really depends on the person. I've worked with people who they have a reasonable benefit from a dopamine agonist drug, but then they develop side effects as we push the dose and really don't get much benefit from it beyond what had helped before. We pull them off, maybe switch over to levodopa. That works well, but then they have that wearing off response. We push the drug up, and sometimes we use both. One to get the main push, the workhorse effect, but then the other to kind of smooth out the wearing off between the doses. So it's very empirical. It really depends on the person. It depends on how that person responds to the medication, combination of medications, and equally importantly, the downsides, the side effects to using both. So it really, everybody gets their own look in terms of using the medications. Now, if there are a lot of side effects, then I'll, from one of them, then I'll pull that off and try to use the other as the workhorse, because sometimes when you have them both on board at a kind of a low level and you have side effects, you can't really push one or the other to see where the benefits are. So you kind of have to pull one down and then push. So everybody is their own, I hate to say experiment, that's the only word that's coming to my mind right now. You have to work with each person individually to find what works best with the least side effects. The question is about stem cell research. So people are doing stem cell research. There are, I guess, a lot of levels to thinking about that. There are a lot of areas in the brain that are affected in Parkinson's disease outside of just the dopamine system that I've talked about. So where do you put the cells? Number one, do you put them in 20 different places in the brain? That could be a little tough. Even in the animal model systems where people are placing stem cells, stem cells are immature cells that have to be made into nerve cells, and then they have to survive in the brain when you put them in. They have to move towards and interact with other cells, and then they have to act the appropriate way to get the signaling to happen so that people can move. And so that's being worked on vigorously, but the survival of the cells and having them mature into functional cells that actually produce the effect that you want is a hurdle. The other thing that we've been learning in recent years that I think will be overcome is that putting brain tissue into the brain of a person with Parkinson's disease will often develop Parkinson's disease. So there are older studies where scientists took fetal tissues and put them in a Parkinson's disease brain, and when that person died, the fetal tissue was maybe 12, 14 years old, but the tissue had Parkinson's disease. So either the environment had changed those cells in such a way that they developed the disease, or one of the other kind of hot theories now is that the abnormal proteins that form those Lewy bodies can actually spread from cell to cell. So those proteins may have invaded the grafted cells and caused them to have Parkinson's disease. So the quick answer is yes, but there are a number of hurdles that need to get over to make sure that they survive the graft, that they function appropriately, and that they don't develop Parkinson's themselves. But all of that's being worked on. Okay? All right, you got it. All right. You got it.